Let me find the screen to share. Let's see if this works. Does that work? Are you seeing my slides?
Looks great.
Okay, great. Well, welcome everyone. Thanks for joining us today. I'm sure there'll be others to join. And if you have any questions, feel free to answer them in the chat. Julie will be collecting them and letting me know at the end, or interrupting me if they're urgent, I suppose. So thanks for joining. So here's the outline for today. We'll talk a little bit about the background for Alzheimer's disease, some patterns of cognitive aging, then what are some of the risk factors. We're not going to go through every risk factor, but some of the important ones that may increase the risk for dementia and Alzheimer's disease, and then some of the ways of combating that risk. Discussing how we're now approaching some of these risks is really something we need to think about our whole lives and not just towards the end of life. And then a study that may be looking at ways to intervene for these risks. So demographics. So what does I see some people on the video here, so maybe I can get some visual responses when I do this in front of an audience. Of course, people raise their hand. What disease do we fear the most? Well, what did your parents fear the most, right? Cancer, wasn't that it? If we had to ask your parents. And so cancer, stroke, diabetes, that worries people, of course, and maybe cancer worried more of the last generation. But if I were to say what disease do we all fear the most now, Alzheimer's disease comes up as the number one. And even though we'll speak about that, actually your risks nowadays from Alzheimer's disease may be less than in the past because of some of the things we're doing for our health. I think we hear more about Alzheimer's disease, don't we, from our friends and family, and that's because the age of people are increasing. Age is a risk factor, of course, for Alzheimer's disease, so I think we're hearing about it more than maybe your parents did in the past. The projections for Alzheimer's disease, you can see, the arrow is a little bit off. We're should be a little bit to the right here. We're already in 2020, and we think there are about 5.6 to 5.8 million people overall in this country with Alzheimer's disease. The graph just shows a little breakdown by age, the older age, kind of middle older age and younger older age. And then by 2050, that number is expected to nearly triple if we are unable to do anything to stem the tide of people developing Alzheimer's disease. So really huge segment of the country affected by this disorder. As I said, 5.5 million. This slide was a couple of years ago, so a couple of million, a few 100,000 less. It's an enormously expensive disease, both in direct costs in caring for the patient and indirect costs in helping caregivers, because Alzheimer's disease affects not only patients, but affects the loved ones who have to care for them as well. And it is the most expensive disease in America, even though it is not the most common disease in America. Now considered to be the 5th leading cause of death among Americans age 65 and older. If we were to look at the drug trials over the last 22 years, so back all the way to 1996, there are really just 4 drugs that have been approved for treating Alzheimer's disease. Donepezil back in 1996 used to be called Aricept, rivastigmine or Exelon, galantamine or Razidine, and memantine or Namenda was the last approved drug in 2003. That's more than 17 years ago. More recently, a combination has been approved, but that's not really a different drug, just a combination of 2 drugs. And you'll see here the number 146, probably over 150 now since this slide was made, of failed drug trials for Alzheimer's disease. Just a kind of sorry state of affairs in terms of treatments. And so the field is really looking for other ways to try to make an influence on the disease. And as I'll show you in later slides, perhaps some lifestyle factors really can make a difference. So some patterns of cognitive aging. So this slide, this kind of background here in the gray, is meant to illustrate various trajectories that people's thinking might follow from their birth early on all the way to later in life and death. So here's one trajectory. Person might start out at a very high level of cognitive functioning. They do decline over their life, but maybe they wouldn't reach dementia until they are nearly 100 years old, if they actually happen to live that long. Another trajectory, somebody might decline more quickly and might reach dementia at the age of 80, or they might start out at a lower level and reach dementia near the age of 70. But let's just take one course that might be typical for someone starting out at maybe an above average level, declining over their life, hitting dementia at around the age of 75 or so. So we'll put a little arrow there as when they might develop dementia if they reach that age. But let's say we could do something along the way. We have some intervention, and we'll talk about those interventions in the course of the discussion today. We might intervene early on in their life, middle of their life, later in life, if there was something we could do. And by intervening, we might change the trajectory just slightly in this person so that instead of them hitting dementia at what might be an age of 74 or 75 or so, maybe they hit it instead at the age of 85, again, if they happen to live that long. So we have managed to delay in this person, this hypothetical person, the onset of dementia by nearly 10 years, if not a little bit more. Well, if we did that successfully, it's almost like curing them in a way if we prevent them from developing Alzheimer's. And studies have shown, as illustrated in this graph, that if you delayed here in the blue, the onset, if we were able to delay the onset in the population of Alzheimer's disease by just 5 years, then by that time of 2050, there would be a 50% reduction in the number of adults with Alzheimer's disease, because unfortunately, none of us live forever. We all have medical problems. We all have a finite lifespan. So if we can delay the development of dementia and as a cause of dementia, Alzheimer's disease, sufficiently, people might not reach dementia. They might not reach a diagnosis of Alzheimer's disease. It's kind of like a cure in a way. Let me just mention some terms here that I'll use throughout the talk and want to make sure you're familiar with it. This is a cartoon. On the left is a cartoon of normal nerve cells. We see in purple the neurons or brain cells. On the right, we see what some of those cells would look like under the microscope as a cartoon in patients with Alzheimer's disease. So you'll hear about the plaques or the amyloid plaques, because amyloid is a protein that's in our brains and for reasons that are not always clear get deposited in patients with Alzheimer's disease and form these plaques that are in between the neurons. And we think that something about the accumulation of those plaques or the collection of amyloid influences the development of what are called the neurofibrillary tangles. And these are other proteins that are inside the cell, primarily consisting of a protein I might mention called tau. So we have amyloid in the plaques, tau in these tangles, and these tangles kind of mess up the transport within the nerve cell, damage the nerve cell so that it's not functioning correctly, and then lead, of course, to the development of all the symptoms of Alzheimer's disease. Here it shows on the top, tau, the tau protein, are part of what are called microtubules. Think of this as a scaffolding within the neuron, kind of like a transport system, almost like a monorail in the neuron by which the cell can transport proteins and other parts of the cell from the cell body of the nerve cell all the way out these axons to connect with other nerve cells. And if that tau protein, which is affected in Alzheimer's disease, is disrupted, then this scaffolding is no longer good anymore, no longer can do that transport, and the nerve cell malfunctions. Outside the neuron, again, there are these amyloid plaques, and these degenerating fibers of the nerve cell go through the amyloid plaques and may be influenced by it. And then we see here, healthy brain up at the top. This is kind of what we call a coronal or frontal section of the brain. But as Alzheimer's disease progresses, there is mild, and then eventually more and more shrinkage of the brain as those nerve cells are damaged. So I may mention amyloid and tau and the damage that happens with Alzheimer's disease. So I always ask, is Alzheimer's disease a disease of old age? Let's see, I can see people are on their video. Raise your hand if they think it's a disease of old age. Is it a disease of middle age? Who raises their hand for middle age? No, everyone's not sure. So we have actually learned that Alzheimer's disease, I'm going to show the graph, we make the diagnosis when people are older, but those changes in the brain start out at a much younger age. It would surprise you to know that some of those changes start actually 25 years before the diagnosis. So here in this graph, let me just orient you here. On this y-axis, the standardized difference, think of this as some measure that's going to take place. And I'll show you the different items that we're measuring as I display the graph. And then at the x-axis at the bottom are the number of years. And this is the number of years either preceding when people are diagnosed with dementia, which we'll call time zero, or after the diagnosis of dementia, which we'll say here plus 10, plus 20 years, and so on. And before people get diagnosed with dementia, they often come in with what's called mild cognitive impairment, or kind of a prodromal set of symptoms where they have some memory loss, but they're not quite so impaired yet. So time zero here we will say is when the person has sufficient symptoms to get diagnosed with dementia. Now, through sophisticated imaging experiments and experiments in which people had actually spinal taps to measure these proteins, or they've come to autopsy and their brain has been studied both before and after the diagnosis of dementia, we find that these beta amyloid plaques, they start to build. They change from what would zero would be where the level would naturally be, but that level starts to build up 25 years ahead of when people are eventually diagnosed with dementia. That tau protein, that begins to build up about 15 years ahead of time. The hippocampus is a structure in the brain related to memory. And so we can, on special MRI scans, we can measure the size of this structure of the brain. And if the structure is shrinking, I showed you that the brain shrinks with Alzheimer's disease. So this structure starts to shrink, which corresponds to the memory loss about 10 to 15 years before people are diagnosed with dementia. And finally, we can measure their cognitive and functional abilities over time using something called the clinical dementia rating scale. And that only begins to change maybe 5 years to 10 years before the diagnosis of dementia. So we notice subtle symptoms that begin a few years beforehand and then increase, and then finally someone's diagnosed with dementia. So dementia, which is this umbrella term that means a person has problems with thinking that interfere with daily life, that happens after all of these other changes are taking place in the brain. Right here, this area, once people are diagnosed with dementia, this is where those drugs are now being given after the changes have taken place in the brain, after all the symptoms have developed. We're now looking at drugs that try to intervene a few years before, but as you can tell from the level of tau and amyloid, a lot of changes have still taken place in the brain. What we would like to do is do things even earlier in life where we might be able to influence the levels of these proteins so that we never get to dementia. So no time like the present. It's never too early to start, but also we can do some things later as well. Okay, and let's go on. So let's talk about some Alzheimer's disease risk factors and lifestyle interventions. So in this slide, we've really found that there's a whole slew of things, whole set of both lifestyle choices we make, but also how we're born and our genes that influence our risk for Alzheimer's disease. So here in the green, we are born with certain genes such as the ApoE and other genes, and familial influences that increase our risk of developing dementia. And of course, those things are present at our birth. And late in life, here at the end, neuronal damage or vascular insults, if throughout our life we've gotten head injuries or vascular, meaning stroke, we've had strokes, of course, that's going to influence how we're doing later in life. But as you can see here at the top, there are negative risks, unhealthy dietary choices throughout our life, misuse of alcohol, smoking, poor sleep, and so on, that are influencing us not just at the end of life, but these are choices we're making across our lifespan. Similarly, there are good choices: early life education, physical activity, healthy diet, and cognitive and social activities throughout our life that actually function as protective factors. And people are estimating, when this slide was made, maybe about a third or a little more of our risks for Alzheimer's disease are among all these factors, and we can modify them throughout our lifespan, and that may make a difference later on in life, and that's what's being studied now. Okay, we all would like, patients come in there like, can I be on Prevagen? Can I take a smart pill? Will resveratrol make a difference? I like the little guy lifting the brain weight there. It's making our brain stronger. None of this works. Sad to say, nobody likes the pills from the doctor, but they all like the pills they advertise on TV, right? And we would like to be able to take a pill and make ourselves healthier, but we're going to have to work a little harder than that. And so, unfortunately, the supplements don't make a difference as far as we can tell now. But what does make a difference, perhaps, is modifying our lifestyle. And we'll talk about exercise and diet and so on. All right, let's talk about exercise first. So this is a study that was done with a brain MRI scan illustrated here, and they measured the size of the hippocampus. So the hippocampus is a little structure in the brain that is covered in yellow here on either side. It's a small paired structure. It measures a few millimeters to a centimeter in size or so, and we can measure its size. And when your hippocampus shrinks, that's often goes along with some memory loss being present, and we can use very sophisticated MRI scans and analysis techniques to measure that size over time. So what did they do in this study? They took 120 people and divided them into people who did actually pretty mild amount of exercise, about 40 minutes of walking, brisk walking per week. Average age in the upper 60s, similar average age in the control group. And the control group didn't do any extra aerobic exercise. They just did, for example, stretching. So one group aerobic exercise every week, at least 40 minutes, one group just stretching. And they measured at 6-month intervals the size of this hippocampus and found out that in the blue here, in the intervention group, that hippocampus seemed to be going up a little bit in size, but in the group that did not have any aerobic intervention, the size of the hippocampus was decreasing. Now, this is not the same as knowing whether those people would have developed Alzheimer's disease, but for my money, things that are preserving the areas of the brain that have to do with memory, that sounds like a better choice than activities that don't preserve those areas of the brain. There have also been a variety of studies that have basically taken a poll in people over time. So they haven't yet, we're now just doing the studies where we actually assign people to exercise or not exercise. But there have been a whole slew of studies in which we asked people how much exercise we did. We tabulated that, we followed them over time, and then based on that tabulation, how much they told us that they were doing, we didn't necessarily follow them. We examined whether or not they developed cognitive problems later in life and dementia. So in this study, about 1,449 people, this was a cardiovascular risk study. So they were looking at exercise and cardiovascular status. And they followed them from the ages of about 50 to 71 or so, and to determine what their thinking abilities were. And they were asked about, they weren't assigned, they were just asked about whether they did activity that they classified as moderate exercise. So about 20 or 30 minutes of aerobic activity that caused breathlessness and sweating, and then examine, if people did this a lot or a little, and then what was their risk of developing dementia. And what they found is that people who were in the more active group, they had about half the risk, the odds meaning how much risk out of, versus 100%. So half the risk in the group of developing dementia, and almost down to a third of the risk of developing Alzheimer's disease. So people who were more active had less risk of developing either dementia or Alzheimer's disease. In another study, 1,740 people over the age of 65 again reported their physical activity, were followed up for an average of 6 years or so, and their rate of dementia for those who exercised more than 3 times per week was a third of those who exercised less than 3 times a week, right? Was 2/3. It was down by a third, approximately. So again, exercise, people reporting that they're exercising more frequently, those people seem to have a lower risk of dementia. Well, this has now been examined in multiple studies. This is listed here. All the details are not important. Look here over on the right. So see this green line? The green line would be if there was no difference between more activity or less activity. If there's a little diamond to the left of that green line, that favors more activity being associated with lower risk of dementia. Diamonds on the right side of that green line would be associated with less activity. And if you take all of these studies and kind of summarize them down here in the red circle, so overall, all of the studies that have looked at exercise, and again, asking people about their exercise, not necessarily assigning them, those studies overall suggested a lower risk of dementia in that group. And similarly, when studies have examined not just dementia, but Alzheimer's disease, lower risk for Alzheimer's disease in groups that exercise more. So if we were to take all of these results and summarize them, reporting that you do more exercise seems to improve, be associated with improved cognitive abilities and lower risk of dementia. RCTs, that stands for randomized clinical trials, where we assign people to one group or the other, and those are ongoing now. How much exercise do you need? Well, we don't know. It's ranged from 40 minutes a week to 225 minutes a week, a little less than 4 hours a week. Somewhere in the middle, 150 minutes a week is approximately what's recommended. 30 minutes a day, 5 days a week, approximately. And we think that is a reasonable dose of exercise, but studies may eventually show a little more, a little less. How intense should the exercise be? Well, you don't have to train for the marathon, but it should be of a moderate degree, not just strolling along, but assuming you're healthy enough. And would always advise checking with your primary care doctor if you haven't been exercising, but exercise of a degree to cause some breathlessness, some breathing more quickly, and some sweating. And we think in some studies that a little more strenuous, so the more you do, a little bit better. And of course, check with the physician before doing that. Well, the next topic is diet. And here is the illustration of the food pyramid associated with the Mediterranean diet. So down here at the bottom, the things that you're supposed to eat the most of: brightly colored fruits and vegetables, nuts, whole grains. If you're going to use oil, olive oil. Next level in terms of consumption are things like ocean swimming fish and other seafood, chicken. They have here dairy, for example, and eggs as the next level. And we really should have not much red meat and not many sweets. I say people don't eat too many donuts, right? Those are not so good for you. So that's the illustration. Drink plenty of water. And in the Mediterranean diet, people have typically had some alcohol in moderation. Well, this has been studied now in a number of studies to see how, how much benefit this diet would have. And there have been some other diets that have some similarities to it. So Mediterranean diet, as I've emphasized, olive oil, legumes, whole grains, fruits, vegetables, fish, dairy in the particular Mediterranean diet, but lower consumption of meat and meat products. And again, in the Mediterranean diet, some wine consumption. Other diets that have been studied include the DASH diet, dietary approach to systolic hypertension or systemic hypertension, is very similar to the Mediterranean diet, very popular diet, and has very similar emphasis. And then out of Rush, over the last few years, Rush University in Chicago has been a group that have promoted something called the MIND diet, really reflecting a combination of the Mediterranean diet, the DASH diet, and the idea is that it will help delay the onset of dementia. So this study looked at a little over 900 participants, and what they did was they followed them for 4.5 years. They didn't prescribe a diet, but they assessed them with a food questionnaire. And by asking what people ate week by week, they're able to figure out how well the diet these people are on conformed to either a Mediterranean diet, a DASH diet, or this MIND diet. And of course, there's going to be some overlap in that. So if you naturally ate a lot of fruits and vegetables, fish and some chicken, not too many sweets, you would have a high conformity with these diets. And if you didn't eat those things very much, you ate a lot of donuts and red meat and so on, you really wouldn't conform to these diets. Okay, so, and the MIND diet, the difference is that they felt it emphasized more brain healthy foods. So for example, there have been some studies that have looked at berries and blueberries and things like that, and not just high general fruit consumption. And they feel that's a little bit better. And the MIND diet has lower dairy and lower potato consumption than things like the Mediterranean diet. So let me show you what this sort of food questionnaire looks like. So it's something like this. There's a dietary component here on the left. And then in these columns, you can either score 0 point, a half a point, or 1 point in the MIND diet, depending upon the component. And let me show you. There are some things outlined in green that we consider good for you. Green leafy vegetables, berries, nuts, olive oil, and so on. And the more green leafy vegetables you have per week, if you have 6 or more servings, you get a point. If you only have a couple servings, you get 0 points, and so on. Other vegetables also give you a point, and berries and so on. Whole grains, fish, beans. The more you eat, you get a point for that. And if you follow all of these points, they add up to a maximum of 15. There are other things where you get a point the less you eat of those things. So the less butter, margarine, and cheese you eat on the MIND diet, you get a point. The less red meat, fast fried foods, and pastries and sweets, you get a point as well. And in the MIND diet, if you had a glass of wine a day, you get a point. If you had more than that, no points. So if you follow all of these things, you eat the good things, you don't eat the bad things, then you can get as much as 15 points. People who adhered pretty well generally scored in the 8 to 12 point range. People who adhered modestly on this in the 6 to 7 point range, and people who adhered very low in the 2 to 5 point range. So let's see how this looks over all these diets. And similar questionnaires were given out for the Mediterranean diet and the DASH diet. So people were divided into thirds based on how well they followed the diet. If you were in the top third, here called T3, in this case, the Mediterranean diet had 55 points. So each diet had slightly different point scores. But the idea is if you were in the top third, middle third, or lower third, let's look at what that looks like. So the closer you stay in this graph to 1, the less likely you have Alzheimer's disease. So what this 1 means is at the top level, 100% here don't have Alzheimer's. As you start to go lower, for example, at here, about 85% don't have Alzheimer's. But, and that's if you follow the diet very well. So this dotted line corresponds to the top tier. But if you did a poor job with the diet, then by the end of 8 years, then 70% of the people didn't have Alzheimer's, 30% did. But at this point, only 15% did if you followed it well. So that difference, if you didn't follow it well, more likely to get Alzheimer's. If you did follow it well, less likely to get it, and about half the risk, that relative risk, again, about half. Similarly, for the DASH diet, if you followed it really well, this dotted line, lower risk of developing dementia and Alzheimer's disease than if you did not follow it well. And same thing for the MIND diet. If you followed it well, less risk of developing dementia and Alzheimer's than if you didn't follow it well. So in all of these three diets, because they all have a lot of similarities to them, any of them are valid, the better you follow the diet over many years now. Of course, you could follow the diet, tomorrow, but that's not good enough. You have to follow it over many, many years. If you stuck with it, your risk of dementia was about half, as if you didn't stick with the diet. And so the summary is reported adherence to any of these diets have really good benefits for your cardiovascular health, and they reduce your risk of dementia. But again, our randomized controls trials are pending, and we're starting to do those now. And the better you adhere to those diets, the better you do over time. Let's talk about another way to intervene, cognitive training and leisure types of activities. People are always saying, well, Dr. Gitelman, should we do Sudoku? Should we do a crossword? Should I do a Rubik's Cube? Is there a game on the computer I should do? What about other things? What about if I wrote a letter? What about if I went and, did some reading and so on? Do those things have any benefits for my brain? Well, here was a study that started to look at some of that. And what they did here is they took some subjects and they asked them about the cognitively stimulating activities they did throughout their lives. So, for example, did they read books or newspapers? Did they write letters or emails? Did they go to the library? Were there games or puzzles that they played? And these people underwent a special type of PET brain scanning that measured this amyloid in their brain. And I'm just showing you an illustration at the bottom here of what that might look like. So in people who have very low amyloid in the brain on the left here, we just see some of these brighter colors indicating amyloid deep in the brain in the white matter. But we see very little amyloid around the cortex of the brain, where all those nerve cells are that help relate to our memory and our thinking. On the other hand, a positive amyloid scan, we now see all those bright colors out near the edges of the brain in the cortex. Well, it turns out we can take these types of scans and we can come up with a number that measure the amount of amyloid in the brain. This brain would have a lot more amyloid than in this brain. And we can do that in different groups of people, young people, old people, and we can stratify or separate people now by the amount that they're doing these cognitively stimulating activities. So let me show you that in the next slide. So here's all the groups of people. In this group, these are young control people. So these are all young people. And of course, we expect very little amyloid in the brains of a young person. They don't develop Alzheimer's disease when they're in the younger age group in their 30s or so. And so they have very little amyloid in the brain, low number for the amyloid. In contrast, people with Alzheimer's disease, they have, in general, much more amyloid in the brain, as we suspect, because we talked about originally that the accumulation of the amyloid is something that happens generally early on in Alzheimer's disease and leads to the other symptoms of the disease. Well, what about just older control people? Well, they found that people who had the most cognitive activity seemed to have the least amount of amyloid in the brain. Middle amount of amyloid, and the lowest cognitive activity, lowest amounts of amyloid. Now, we don't know, does this mean the more you participate in those thinking activities, you're actually lowering your amyloid? Well, we'd like to think so. On the other hand, it may just be that people with lower amyloid in their brain are able to participate in these higher levels of cognitive activity. And so that's something that's still being investigated. People were followed over time, and they were asked again about the types of thinking activities they participated in. So about 1,375 subjects. They were older, in their 80s, and they were followed over 7 years' time. And some obviously once you're in your 80s, some were alive at the end, some had passed, and about 123 had developed dementia. And they responded to a poll, to a survey, in which they described the type of activities they were involved with. Let me show you that on the next slide. This is a complex slide, but I'm going to outline it for you as we go. So here on the left are these various activities they surveyed people about. So there were things they called mental activity: reading, writing, studying, crossword puzzles, painting, or drawing. And what they found is they compared people who did very little of that activity, what we'll call no here, with people who did that either less than daily or daily. And what they found here in this relative risk column is that compared with the no group, compared with kind of like a placebo, or the group that didn't do much of this activity, people who did more of it had a lower risk of dementia and Alzheimer's disease. So the more of these activities you did it daily, it was a benefit over time. Similarly, here's our physical activity group. Well, we spoke about this already early on, and we said that if you exercise daily, your risk of dementia and Alzheimer's disease was a lot lower, and they replicated that. They found that in that survey. Other things that people can do, however, is not just puzzles or reading and writing. There are social activities. And this is something that the coronavirus has been particularly hard in, right? So all of that socialization that we're used to participating in, we can't do that now. And that's really a negative for a lot of people's thinking abilities. Going out to theaters or concerts, art exhibitions, and so on, those people had a lower risk of Alzheimer's. If you did other productive activities, gardening, housekeeping, cooking, and so on, again, a lower risk. But those who did more passive things as their primary form of activity, there's nothing wrong with watching TV or listening to the radio, but if that's all you did, or if that's the primary thing you did, not really a benefit. So this 0.95 number, not much different than 1, meaning there isn't a lower risk of doing these things daily. All the other activities here that involved more socialization or mental activity or physical activity, all of those seem to lower the risk for Alzheimer's disease and dementia, but not when people were more sedentary or passive. So, summary: mental, social, productive activities may have benefits in reducing the risk of dementia. Activities that are cognitively stimulating may affect, as a possibility, some of those biological markers of Alzheimer's disease, things like amyloid that I brought up. And we don't yet have enough information to recommend specific training programs. All right, last thing we'll talk about today is sleep. So a study was done, again, looking at this amyloid and to see how it was affected by sleep. So we know that disorders like sleep apnea increase the risk for a variety of vascular conditions, high blood pressure, cardiovascular disease, diabetes, and so on. We know that in some people with sleep apnea, they'll breathe so poorly at night, their oxygen will go down, and that oxygen can injure, lower oxygen can injure brain cells. And sleep deprivation may has been known to increase brain amyloid. So this was studied, and what they found was that in people who slept on average less than 6 hours per night, and they underwent this amyloid scanning, PIB is a special compound that measures amyloid. So high levels of this compound in the brain, as you can see here, was associated with lower sleep. Lower levels of this compound, except that we naturally see it in the brainstem, was associated with more sleep. So it may be the case that the more you sleep, the less that amyloid accumulates in your brain over time. Other studies that have been done, there's a very large study in the United States that has looked at imaging in people over time and whether they develop Alzheimer's disease or not. And they've studied normal people, people with mild cognitive impairment, and people with Alzheimer's disease, and have followed them over time and measured different aspects of their lives. So in this case, people were asked about whether they had a history of sleep apnea that was untreated or they did not have sleep apnea. And the no sleep apnea group in blue, the sleep apnea group in green. And what this shows is that if you follow people over time, people who did not have sleep apnea had a lower risk. Remember, the higher number on this graph over here is a lower risk of developing Alzheimer's disease than people with sleep apnea. And on average, the time of onset, if you did not have sleep apnea, people averaged an age of onset of Alzheimer's disease in the late 80s, but those with sleep apnea in the early 80s. So it seems that the more sleep apnea you had, the earlier potential age of onset of Alzheimer's disease. Now, what if we treated these people? What if we treated the sleep apnea? We don't know the answer to that question yet. So, sleep summary: poor sleep may increase some of the biological markers of Alzheimer's disease, like amyloid. Sleep disordered breathing may increase the risk of dementia. It may also increase the risk of vascular dementia, for example, because of its cardiovascular risk effects, and may lower the age of onset of Alzheimer's disease. And we think about the recommended amount of sleep is about 7 or 8 hours. Okay, so we've talked about the fact that there are many risks over a person's lifespan that may figure into the development of Alzheimer's disease. We've also spoken about the fact that these risks, that these studies that have been done so far have mostly been survey types of studies, but not the types of randomized trials that would prove whether doing one or these other things would make a difference. And in fact, when this has been looked at, the US Preventative Task Force and the NIH have found that there really is not enough evidence yet. There's not enough, what they call the magic bullet. Is there, one thing that you can do or more than one thing that you can do to prevent dementia? And what they're saying here is, we don't know yet. We have a lot of circumstantial evidence to suggest that these things are all beneficial, but we don't know whether to tell everyone to go out and exercise or eat properly. And those studies just have to be done. We do know that there are many factors that make it difficult to make this assessment. We don't have these randomized trials that we're now doing. So important to participate in these trials. We don't know, as I mentioned, does the factor cause the disease or vice versa? So for example, we know depression is associated with dementia. Is it the case that depression causes dementia? Or is it the case that if you're demented, you're just more likely to be depressed? And so in the one case, maybe if we treated the depression, we'd have a lower risk of dementia, but in the other case, not. And we're still learning many of these things. There may be common underlying factors for these various risks that confound figuring out which one is most important. And then, as I like to also say, well, the correlation is not necessarily causation. So the fact that two things go together doesn't necessarily mean that one causes the other, and we need those randomized trials to figure that out. So just as a fanciful example, here we see an extraordinarily high correlation. If this R number was 1, that means perfectly correlated. And here, the number of people who are dying by becoming tangled in their bed sheets is highly correlated with per capita cheese consumption. I don't know if this is true or not, but I don't eat cheese and crackers in bed anymore, I'll tell you that. All right. So we also know that in the US, as I mentioned, despite the fact that we all hear about Alzheimer's disease all the time, we know that the rate of it is actually falling somewhat. We just hear about it more because there are more people living to older ages. And we think a lot of this has to do with improved cardiovascular health. And so there's certainly a lot of circumstantial evidence that what's good for your heart is good for your brain. And all the things that I'm talking about here, exercise, diet, cognitive engagement, and sleep, all of those things are likely to be a benefit over time. We're now taking more of what we call a life course approach. That it's not that we just need to intervene later in life, but there are all these factors throughout our life that each contributes a little bit of a percent to our developing dementia or potentially developing dementia and Alzheimer's disease later in life. So starting at a very young age, early in life, all those early stage programs, Head Start and the like, lower educational achievement early in life contributes actually 7% to the risk of developing Alzheimer's disease later. In midlife, things like hearing loss, history of traumatic brain injury, high blood pressure, excessive alcohol use, and midlife obesity, all of those things contribute to developing dementia later in life. And then late in life, history of smoking, depression, social isolation, physical inactivity, actually air pollution contributes. So having a healthy environment is very important. And diabetes, all of those things have increased contribution later in life. And now this is a revised diagram, not just 35%, but maybe as much as 40% of the risk for developing dementia later in life is actually modifiable by you and I, right? So if we intervene for all these things, we get our hearing checked, watch our weight, don't overdrink, treat our high blood pressure, treat depression, we exercise, and so on, that can make a huge difference over the course of our lifespan. Okay, so some studies have started to do this, and this has a lot of good news to it. So in 2015 or so, they reported out a study called the FINGER study, and FINGER is some acronym in Finnish. This was done in Finland, and they did a 2-year study in which they specified nutritional, exercise interventions, cognitive training, and vascular monitoring, followed people over 2 years. So one group got all of these interventions. The other people went to their doctors, they got their regular health advice. So they got as much advice as anybody would normally get in Finland, but they didn't get all the special interventions. And they followed that group for 2 years. What did they find? So, just to say, there were 1,260 people. They were between the ages of 60 and 77. And again, they had this multi-dimensional intervention, a dietary intervention, exercise, cognitive training, group meetings, social, and management of metabolic and vascular risk factors. And again, this was just first a group with regular standardized health advice. And what they found was quite remarkable. Even in just 2 years, if you looked at an overall neuropsychological test battery, people were 25% better in their cognitive performance. Executive or planning functions were 83% better in the intervention group. Their speed of processing was much better, and memory on complex tasks was better as well. So all of these areas much better in the intervention group after just 2 years. So lower risk of cognitive decline, lower risk of functional decline, better health-related quality of life. And in fact, if you look at the risk of developing other medical diseases, people who were in the intervention group had a lower risk of developing additional 1, 2, or 3 other additional medical diseases, such as stroke or cardiovascular disease, than the non-intervention group. So people much better, okay, much faster. And importantly, this was not just super aging people, right? They didn't just recruit people kind of at the top echelon, wealthy people or people who, just naturally were athletes and the best people. They recruited average folks. And no matter what your socioeconomic status was in Finland, if you followed the program, you did better. And that's really important. And it also, it didn't matter even if you had a risk factor for Alzheimer's disease called the ApoE4 gene. Anybody who followed this and did it reliably did better over time. Well, we're starting to implement this in this country as well. So there's a study called the US Pointer Study. It's going to be a 2-year clinical trial of 2,000 healthy older adults in the United States at 5 different cities in the United States. And it's going to test in a very diverse population. You know, do you have to be from Finland to make this work, or can we make it work in regular Americans too? And so there'll be physical exercise, nutritional counseling, cognitive and social stimulation, and management of health status. People in the study, they want people who have a sedentary lifestyle. So if you're a couch potato, if you're already the person who's training for the marathon every day, you've achieved the benefits of the study, right? If you're already eating the Mediterranean diet and you're running every morning or whatever you're doing, then you're already doing a great job. So we want people who are not quite doing that great a job in their lifestyle, but want to improve. So people who are sedentary, poor diet, they have a suboptimal cardiovascular status, so high blood pressure, high bad cholesterol, high measures of sugar in the blood, or they have a family history. Any of those people can be part of the study. And they're looking at people who are in 2 interventions in the study. In one case, people will be given all the information they need to make the lifestyle changes themselves. This is called the self-guided group. So you'll be given information about exercise and diet, but you've got to go and do it. And in the other group called the structured group, those people are going to be followed more closely to make sure they adhere to things. So one, you kind of got to do it on your own. The other, we make sure you do it, and they'll look for the difference between those 2 groups. 5 sites throughout the US. The main site started out at Wake Forest in North Carolina. In Chicagoland, both Rush and Advocate are participating and are both sites for the study. I should emphasize that although at Advocate, this is being done at Lutheran General Hospital, you only have to visit the research site twice a year, but most of the study is taking place at your local YMCAs or fitness centers and so on, or even at home in the pandemic. So you don't have to come into the hospital for all that. You can do most of this in your local neighborhood. Other sites up in New England, down in the South in Houston, and over in the West at UC Davis. So we're really trying to recruit a diverse population of people. Other tests that'll be done, there'll be imaging tests done. We'll look at the gut microbiome because we now know that the bacteria in your gut have a big influence. They'll measure sleep, and they'll also measure cardiovascular status as well. So to summarize, we talked about exercise, about 150 minutes a week. Light weightlifting may also be beneficial. We've talked about this healthy diet, Mediterranean or DASH diet or MIND diet. Any of those are diets that have been shown to potentially have some benefits. Mental exercise of various sorts, beneficial. We've talked about getting regular sleep. Some things we haven't talked about that I mentioned on that one slide. So management of impairments of vision and hearing, very important. Like we all get glasses, right? But trying to get somebody to get hearing aids, very, very tough. But they make such a huge difference in some people. Treatments for depression, doesn't have to be medications. It might be therapy of some sort, but that may make a difference. Limit the use of alcohol. Obviously, we should avoid head injuries. I'm going to recommend that nobody here go out and play tackle football, you know, that sort of thing. Certain medications have a very high anticholinergic activity. So things like Tylenol PM have this Benadryl in them. This is the fancy name for Benadryl. And over one's lifespan, if you take those medicines very consistently, they may actually increase the risk for dementia. Supplements, none of them, unfortunately, are recommended. So let me, so that's the end of the talk, but let me just spend a couple minutes just telling you about the Memory Center, and there's some of the studies we have going on here, and then I'll answer your questions. So the Advocate Memory Center is focused on state-of-the-art care of patients with Alzheimer's disease and other forms of dementia or people with memory loss. We do clinical research trials as well for dementia prevention. We're part of this US Pointer study and also Alzheimer's disease. Here's everyone at the Memory Center. We have all of our clinical providers, myself, social worker, neuropsychologist, nurse practitioner, and other dementia-focused clinicians, our clinical staff, and our research staff. We have 3 locations. We're at Lutheran General Hospital is the main location, but also down at 95th Street and over at Good Samaritan Hospital now. We have 3 main research studies here now that people may be potentially interested in joining. For people with mild Alzheimer's disease, there's the Clarity trial, and that is an anti-amyloid antibody for people who are ages 50 to 85, and the idea is to remove that amyloid from the brain. In very, very rare instances, there are people born with genetic forms of Alzheimer's disease where they have actually a 50% risk. Usually these are people with very young onset in their 40s and 50s and so on. And we're part of a trial for that. And as I mentioned, we're also part of the US Pointer trial, which is a lifestyle trial for dementia prevention. You can call this number, 847-720-6464 for a clinical appointment, or if you have an interest in any trial, and one of our either clinical or research staff will get back to you. So let me stop there and answer some of the questions before the end of the hour. So let's see, Julie, I see we have a bunch of questions here. Let me start at the top. Are there any newer studies that continue to back up these studies from many years ago? Well, yes. So the studies are really not that long ago. I mean, a lot of these studies have been done within the past 5 to 15 years, and studies such as the US Pointer study are, here, let me take away the slides for a minute here. How do we do that? We stop. All right, did it stop sharing? Yes, okay. So now everybody can see everybody. So these newer studies are now actually doing the high quality randomized interventions that by the end of studies like the US Pointer study, we'll be able to say, if you do all these things, now we know it makes a difference. We're not just guessing. And then, you know, there are all these drug studies that have failed, but we're part of groups that are doing more drug studies because, you know, as the Alzheimer's Association says, the first person to be cured of Alzheimer's disease will be in a clinical drug trial. So one day we're going to figure it out, but it turned out to be, I think, a tougher nut to crack than people figured. Let's see, how do you isolate the activities? So they don't necessarily isolate in these older studies with the surveys, people may belong to more than one group. So they may belong to a mental group and they may belong to a physical group. And you control for that statistic. There are ways to control for that statistically. So you can kind of assign how much you think each is contributing to the reduction in risk for dementia. But in studies like the Pointer study, where you're actually assigning people to different groups, we'll be able to know much better how much the interventions are making a difference. So African Americans have a greater risk, right? So that's so important. So both African Americans and Hispanic Americans have a greater risk, unfortunately, of dementia and Alzheimer's disease. I think African Americans have twice the risk of white Americans, and Hispanics have about 1.5 times the risks. So that's a really important thing. In the Pointer study, we're actually trying to make sure we recruit a diverse population so that we can make sure that the outcomes of the study apply to all the populations in the US and not just a particular segment of the population. We don't know why the risks are increased. We know that people, a lot of it we're kind of assigning to race, but it also may have to do with socioeconomic status. So people of sometimes lower socioeconomic status have less access to healthcare. We know that that even regardless of socioeconomic status, people in underserved populations go to the doctor less, have less access to healthcare, may not get treated the same way at times. You know, I think the way we change that narrative is to be aware of it, to make sure that they're part of the studies that look into this, and we make sure that the results apply to everyone. Let's see. Next question. What about sleeping? Well, I mean, there are some people who are don't have sleep apnea and they're just tired during the day, right? And maybe they don't sleep well at night. You know, there are other disorders that affect sleep at night, and you know, may affect the quality of our sleep. So the important point is not just the number of hours, but also the quality of sleep. But that's kind of hard to measure. You know, when you're at home, I know there are all these apps that do this now. But a quality of sleep is important as well. And if you are getting what seems like a normal amount of sleep, 7 or 8 hours, but you're still really fatigued, then I would suggest talking to your primary care doctor, and maybe a sleep evaluation is in order, because perhaps something else that's going on at night that is interfering with sleep. How does stress reduction? There are stress, you know, stress is very important. We talk about depression, but really stress is part of that too. Stress increases certain stress hormones in our bodies, like steroids, and that affects the brain. So, you know, people I think are increasingly concerned about work-life balance, you know, for those of us who are working, or just stress in daily life. There's so much stress this year, right? Between COVID and everything else that's going on, I don't think we have a non-stressful day. So it is important to de-stress. It is important to, you know, sometimes people do that with exercise, for example, or by the other activities they do. And I don't know how much that influences the development of dementia, but it definitely makes a difference, and we recommend it. Let's see, are there any studies that track those of us who have a parent that has Alzheimer's? What if we are predisposed? There are studies that do track that. There are some observational studies that do track people over time. We're not doing that here. Certainly, if you have concerns about having dementia, you know, I would advise getting evaluated, and there may be a study that's good for you. If you don't have symptoms now, you might be good for being in studies like the US Pointer study, which will ask about family history as well. And then what stage of sleep is considered adequate enough? That's a complex question. There are 4 stages of sleep, kind of 1 and 2 are light, 3 and 4 are deep, and there's REM or dreaming sleep, and each of them have certain percentages. So again, I would just say if you know, feel you're getting sleep, but you're still tired during the day, ask your doctor about that. Do you know about the Iowan study? I don't, sadly. I'm sorry, I have not heard of the Iowan study, so I can't answer your question on that. It tells me that I learned something new from doing these talks, so I'll have to look up the Iowan study. I apologize for that. Yes, Brown, Steve Salloway, who's the PI up in Rhode Island, is affiliated with Brown. He's at Butler Hospital, I believe, and they are doing the Pointer study. What do I make of the claims of Dr. Bredesen that it's preventable? So I will say in general that some of the claims of Dr. Bredesen are not well investigated, but in general, he is promoting exercise and healthy diet, and he also promotes a whole variety of supplements. But in any case, I mean, I think the concept that there are factors that we can do throughout our life that may influence Alzheimer's disease development. I agree with that aspect of it. I think we, rather than just throwing up our hands and saying we should give everybody everything and we don't know, I mean, I think there are rigorous ways to study this. And the Pointer is doing this in a rigorous way. Is it studying every factor, every supplement? No, it's not. That's going to need to be studied in the future. But it is doing it. I think it's important to do it in a rigorous way. Do I think Alzheimer's disease is completely preventable? No, I don't think it's completely preventable. Just like, you know, no matter how Jim Fix, who was a marathoner and was so healthy, and yet he died of a heart attack, right? So there are some things we're born with, no matter how great a life we live, we're just destined to develop some of those. Do I think it's possible that we can delay it? Yes, I do think that there's an interaction with our environment, and that may make a difference. Right, so you know, somebody said that their family has a very high rate of Alzheimer's disease, and so you know that's obviously a great tragedy for your family, and sorry to hear about that. Are there things that you may be able to do for yourself? And yes, I think some of the things we talked about here. And, if it's the case that many people developed it at a very young age in the family, then your family may unfortunately be one with one of these genetic factors. And, maybe there are ways to intervene as part of these studies. Is there no way to detect the early buildup of plaques and deposits? No, there is a way, but we don't know what to do about that yet. So there is a special kind of PET scan called an amyloid PET scan. And we could do amyloid PET scans, but they're super expensive. We do them now when people are going to enter a clinical trial. So if you're going to be in a clinical trial, we do the amyloid PET scan because we want to know if you're supposed to have Alzheimer's disease, there should be amyloid there. So if there's no amyloid, you don't have Alzheimer's. So we're doing them before clinical trials. We don't know what to do with that in the general population. So if I just took everyone here and scanned their brains, yes, some of you all who might be perfectly normal in your daily life might have extra amyloid. What do I do with that? I don't have a treatment yet. So we can detect it, but we're detecting it now in the context of well-designed research studies and not just generally because I don't yet have treatments for it. And whether you had the amyloid or not, I would still tell you to exercise and eat healthy. Prevagen commercials rave about the drug. Yes, that's what advertising does. They rave about the drug. So it's just not tested. So what I always advocate for my patients is to try to tell them things that I think there's a scientific basis for and that have been well tested and that, or, there's at least some evidence. And there are just some things that are promoted where there just is no evidence. There's just no backing to it. And so I can't recommend that. Is there more info about genes? I'm not sure what to say about that. Yes, there is. And if this is a person with a lot of Alzheimer's in the family, please give us a call. And it may be that that's a discussion we should have about the genetic risk factors in your family. And I think I'm going to have to stop here. All right. Thank you all so much for attending and being such a great audience. Very much appreciated. Take care. Bye-bye.